Hello, everyone. Again, after the progress, and this is the labor word management, okay, and what you will be asked for, okay, in this exam, that you will go for the labor word. It's a task, one of the 14 tasks that you will have. So it's considered like one module, so one out of 14, it's a must in the exam. In this labor word, they are testing your ability for not only clinical management, your ability to do a clinical management for the cases, but also to manage the team or to lead the team, okay? To be a team leader. And you can work effectively, with your juniors, with your seniors, and with midwives. You will always face the situation that you are short of staff, okay, in this labor board, and the situation is like, like real life. This is what happened in real life. One doctor is covering the emergency or the labor ward, and the labor ward is busy, so we have to manage, okay, with the availability of staff. So let me give you some hints or some of my tips regarding the labor ward before we go start, and hopefully, guys, that you will apply it in your exam. First of all, this is what you expect to see, okay? This is what you expect to see in the exam. So like, for example, you have 9 cases on the word, or you have 8 cases, right? So you have to deal with them. Sometimes can be more, sometimes can be 12 cases or 10 cases. However, it's not common, okay? But let's say what's common is from 8 to 10, okay? Still, you need to manage your time. You need to finish the task in 10 minutes, covering the domains that applied clinical knowledge, patient safety, communication with the colleague, right? And of course, the information gathering. How will you cover the information gathering from here? It's simply the information gathering from the point in front of you, from this labor word, and from the question that you will ask the examiner, or what type of question. So you will tell the examiner that I would like to know, for example, okay, about the examination finding of the patient, the vital signs, abdominal examination, vaginal examination, and so on. Okay, so when you say that, okay, this is how you take management. If you want to know about one case, so I would like to know if there is any maternal or fetal risk factors. So now you are covering the history and examination. So this is how you will be marked for the information gathering in this station. Right? So this is what I will advise you, my friends, for that you go for the labor word. I'm sorry for this. That you will go for the labor word, okay, quickly and effectively, okay? So, and again, as I always tell you, guys, you are required to be a doctor attending the RCOG hospital in that day, okay? So now you are running the labor ward of the RCOG. The first thing for you that you read quickly the labor word, okay, in front of you. Read it, go through the case quickly, or what is required from you, what is there, how many cases, who is the staff. So it's very important that you read, okay, the requirement from you, and you read what is your task, okay? So situation awareness, where you are, what is the time, very important. Okay, sometimes the handover time can be 8:30, sometimes can be 8 in the evening. Okay, sometimes it can be like 8. So you should be aware. This will help you, especially when he tell you that last examination of a patient who is in second stage was at 7. Okay, so now if I'm at 8, that's mean 1 hour. If I'm at 8:30, that's mean 1.5 hours. So it can help you, okay, in that. So who you are, that's a must, So you are the ST3 or the ST4, okay, in that delivery suite. You arrived at the handover at 8, okay, and this is 8 a.m. Right? This is the list of the patient that on the board that you need to know, okay? And the staff availability of the day are very important. So in your 2 minutes before you start the task, you need to write down, okay, the time where you take the handover, okay? And then you write the staff availability, they told you, okay? And who is with you today, that's very important. The Information about the ability of the staff also is required. How? He told you here, for example, my friends, okay, I think I need to disable something for others. Sorry. Yeah. So the staff availability is very important because you will know who's assisting you today and how are you going to use this staff effectively is one part of your exam, okay? So I have here with me the ST2. ST2 level means what? Means SHO or means registrar? This is SHO, right? And from the matrix of the training, okay, of the RCOG, you should be aware of the what ST2 can do, for example, right? So this is one thing that I will advise you all that you revise it. Go through it once if you don't know really what ST2 can do or what ST3 can do or what ST4 can do. Usually will be combined by SHO, which is the ST2 here in this case. Another one also is there is the ST1. And the ST1 in this case, my friend, is in the 4th month of GB training. What is the meaning of that? The meaning that non-experienced yet, okay? However, can clerk patient, can take vital signs, okay, can do simple measures, or can simple task for you. But I can't really depend on that person that's new in the training to manage a case of obstetric, like for example, sending for ultrasound assessment, right? So be careful of the staff with you and the availability of staff and what is the meaning, you know, of the ST1, ST2, and so on. Okay, okay. So now I know my stuff. I have ST2 and I have ST1. Should I write it down? Yes, please write it down. And you have also a middle grade doctor, a specialist anesthetist, okay, trainee, and the consultant on call, but not yet available on the unit. So it's usually like this. Usually the consultant is there, but maybe in a meeting or coming on the way or whatever, okay? But you should call your consultant whenever needed. 8 midwives are with you, okay? So you have midwife in charge, MD, PK is on, and NN, okay, is can suture episiotomies, and you have also 3 staff or 3 midwives that can insert the IV line, and there is also 1 midwife in the alongside midwifery unit, okay? So you are now in a hospital with midwifery unit, and there is 1 staff there, right? That's good. So I have 10 minutes, like usual, to study the board carefully and then decide what task to be done. So that's mean he wants from you the management of each case. In which order they should be done, that means prioritization is required. So I have to go, or I have to say that this case managed first, this is second, and so on. Okay? And should be allocated, okay, and the stuff should be allocated to each task. So that's mean you need to say who is going to do what, okay, or are you going to send whom are you going to send for every task? Guys, please, I will please ask you if you can just, you know, mute your mic, make sure that your mics are muted because there is some echo there. So again, my friends, the tips, thank you very much. The tips, my friend, for the labor word that we always say, number 1 is situation awareness. Understanding of what I said, it's very important, okay? And the staff availability. Number 2 is what is the task required from you? Sometimes he will ask you the 3 parts. He will ask you management, he will ask you prioritization, he will ask you allocation of the staff. Sometimes not, okay? Sometimes he will ask you only management and prioritization. Sometimes he asks you management and allocation of staff, and maybe divide the task into urgent, semi-urgent, and non-urgent. Okay, so whatever written to you, please follow it. The third advice that I will say that please avoid long unnecessary introductions. Long and unnecessary introductions will first waste your time. Secondly, you will not get any mark for it. Thirdly, it will give the examiner this impression that you are scripted. Okay, what is the meaning of scripted? Scripted means that you are reading a script, you know, so they don't like this, of course, and this is something that will mark you down. So imagine that you are an examiner and you have 14 doctor, and the 14 doctor comes and says the same two lines at the beginning, exactly the same. This is not acceptable, okay, in all the UK exams. Okay, so this is something against the UK standards. Okay, so please don't show that you are scripted. Just go introduce yourself, okay, and say whatever you are willing to do, okay? So after you introduce yourself, greet your examiner, introduce yourself why you are here today. I am one of the part 3 candidates. I have read the board, okay? And I understand that this is a dynamic board, okay? And what I'm going to do is explain what are you going to do, okay? So don't jump in. Please don't jump in. Means that sometimes the people are under stress, so they will say, hello, good morning. I would like to start with case number 8 or 6 or whatever. And I don't know if you can imagine or not, some people even don't say hello or good morning or good evening or anything. Okay, they just go and they start. It's like, oh, I know that the time is needed, so I will start. I will start with room number 4. No, I can't say that, right? It's not acceptable. Okay, it's part of your assessment of the communication. You know, they assessing your communication with colleague while you are performing or presenting. So please be careful of this point, okay, my friends, and don't jump in. Also, explain whatever your approach, okay, after you listen to the examiner. Listening to the examiner is important. Yes, it's important. And please, please listen to the examiner. Why? The examiner will not say anything that unnecessary. Okay? Anything the examiner will say to you is guiding you into how to answer this board today. Okay? He will guide you. Like, for example, some of the examiner will tell you that you have the board, go through the cases, manage the rooms, okay, and they tell me which one is urgent, which one is non-urgent, and at the end you prioritize the cases for me. One of the examiner will tell you, look, I want to tell you what are we going to do today, or I will explain to you what are we going to do today, that you will you have this information. If you need anything, please ask me, okay? And or if you need further information, ask me about it, okay? And then after that, I will expect from you a safe management for this case and prioritization and allocation of staff. This is what the examiner can tell you, but there is difference between the first and second examiner? Yes, there is different. What is the difference? The difference is that the examiner in number 1 is telling you that this is the board, this is your board, and tell me what are you going to do, okay? And I'm just here listening. The second examiner, when he tell you that if you need further information, you can ask about, and I will hand it to you, that's a very nice examiner. That's an examiner is instructed, okay, to give you information only upon asking, means that when you ask about it only, but here he give you a hint, he want to help you, that please do that, please ask for information, okay? So this is 2 types of examiner, as I told you. One of the examiner is just listening to you and he is judging your approach and how safe doctor you are. And the other one, okay, is he have what is called evolving scenario. What is evolving scenario? That means he have some information, based on this information, the management of the case will be decided. If you didn't ask about this part of the information and you just, jumped into the management, this will be considered unsafe management and you will fail. Okay? So very important that you will, put in your mind, what shall I do? Okay? Listen to the examiner instruction again and again and again, please. Okay? And I always advise my candidate, please, in the face-to-face exam, you will have, a piece of paper or you have a notebook or whatever, okay, given to you and a pencil. Please write down whatever the examiner question in structured discussion, okay? Write it down. Even if you write it in abbreviation, like what the examiner wants. He wants 3 things, please write them down, okay? Because you will forget. So write down the examiner question and think about it. Okay, it's not wrong. It's advised. So yes, do it. And please explain your approach. Doctor, I want to go by the urgent room first, then non-urgent, then sorry, semi-urgent, then non-urgent. Okay, if you want to do that, explain that you want to do that. Okay. I myself, I don't do that. Okay, but it's up to you. If you're comfortable with this way and you think that this is the best way to go for it, okay, I am not going to argue with you. But I'll tell you, my friends, sometimes, okay, there is one case on the board that very clearly need your presence now. For example, you have a case of ruptured uterus. You have a case of cord prolapse with pathological CTG. You have a case of shoulder dystocia. Those are obstetric emergencies that we all know that you need to, press the button, okay, for help and call the code if whatever the place where you're working, there is specific code, for example, 222, okay, or 42, or whatever your place, you will initiate, okay, the emergency protocol of your unit, okay, which all the staff in all over the world should be trained on doing that. So if I have something like that on my board, I will start with it. Okay, so my first case is the case that have shoulder dystocia, okay, and I will call for help. I will run to the room. I will do. Okay, so that's mean you have managed the top emergency first. Okay, then you can go room by room. Sometimes it's not very clear. Okay, so case is written there and you are not very clear which case had the top priority from the 2-minute reading, which can happen. Okay, yesterday I was in a session and I told my friends that yes, it happened in my exam. It was 12 cases on the board when there was like, I didn't reach, till maybe the 2/3 of the board. It was very crowded and I was like, oh my God, I'm reading fast, but I can't catch all the cases. Okay, so how I'm going to go and say that I will start by the prioritization first? No, it's not safe to do that. I don't know actually, and I explained that to the examiner that I didn't have the chance to read all the tasks. Okay, but what I'm going to do is I will go room by room, okay, and I will categorize the rooms into urgent, semi-urgent, and non-urgent, and at the end I will prioritize. I was lucky, okay, alhamdulillah, that I was able to finish and prioritize, okay, all the rooms. But the thing is, whatever you feel you're comfortable with, do it. Okay, but keep on track, right? Finish the task with the 3 things required from you are covered: management, or what are you going to do for every case, prioritization, and allocation of the staff. This is what I ask you to do it. How will you do it? It's up to you. Explain it to the examiner and go on for it. Use the SPAR tool in the handover. And I always say use the SPAR tool, and some of you are very comfortable to use it. Some of you, they don't know what is a SPAR tool, okay, of communication. SPAR tool is mandatory that you study it for the part 3. And there are famous structured discussion where you will be asked to perform a phone call or to give a handover. And here, the labor word handover, the handover must be done based on the SPAR tool. And you even can explain that to the examiner at the beginning that I'm going to follow the SPAR tool in the handover. Okay, so what is the SPAR tool? Simply, it is a situation, background, assessment, and recommendation. Situation, what is the diagnosis? What you can see now. It's a case of PPROM. It's a case of preterm labor. It's a case of prolonged second stage. Okay, this is what you will say. Background, what is the background of this case? It's a multi-para with previous cesarean section, for example, okay? Or twin pregnancy, dichorionic, diamniotic. This is what you know at the background of the case. Or the case had fever, or the known case of group B streptococcus carrier, or whatever. Here, the assessment, and remember always the assessment of any case require from you examination of this case. And if the case in labor, usually there is a partogram where you look to the vital signs and the progress of the case, review the partogram, especially for the cases with delay in delivery. If the case is critically unwell case, you need to mention about the muse. You remember the muse? Okay, you need to look at the muse chart for the patient, right? If a patient is postnatal, for example, complain of reduced urine or anuria even, okay, so one of the things that you must say that I would like to review her notes, I would like to review the in and out, right? So this is where you get the assessment. The assessment comes from notes and from examination. Examination, always keep in your mind, okay, graph, okay, or this diagram for a person. Let's say she is pregnant. You can see, of course, this is my horrible drawing, okay? And here I am thinking about from head to toe about this woman. This is a woman, okay? So try to imagine that. Okay, so from head, I'm starting with the vital signs and if the patient is well or unwell, conscious, non-conscious, according to the situation. Then I go to down there, okay? If the patient, for example, she had difficulty breathing, so I need to listen to her chest, have fever, also listen to her chest. If the patient in labor at the moment, okay, I need to check, I need to see the abdominal examination, like for searching for something. What is this thing? You need to mention that to the examiner. In the case of VBAC, for example, I want to assess the, okay, yes, the presentation, the engagement of the head, the descent, and the scar tenderness, okay, and the contraction. Right? So this is what I'm going to say to the examiner. I want to do vaginal examination, and the vaginal examination, I want to say what I'm looking for in the vaginal examination. Like a case 6 cm, but delayed in the first, second stage, delayed progress. Okay, so at least look for the presenting part, any malpresentation is there, or asynclitism or whatever, sorry. And if you have is caput molding, okay, so signs of cephalopelvic disproportion. So just ask this information from the examiner. If the examiner instructed to provide you with some information, he will help you with that, and he will be happy because you did your part. If the examiner from the type that he will stay there, listen to you, and this is what you have already deal with it, he is now, okay, assessing you on the safety of examination and assessment, okay? So now he is ticking the box for you and he give you the mark. He's not only listening, okay? So he give you now the mark. Yeah, this doctor have done the examination so correctly. Take box, okay? And then finally is a recommendation. And recommendation, my friend, is your answer to the case. What I'm going to do with the case. I'm going to move this case for CETR, or I'm going to assess the case for the suitability for assisted vaginal delivery. How? Okay, this is what my recommendation. So for every case, start. What is the diagnosis of the case, or the differential diagnosis at least, or most likely? What is the background, special background in this case? What is the assessment notes, and what is your recommendation? Okay, so doctor, I am not familiar to use this SPAR. I don't practice inside the UK, and I'm not familiar with the SPAR tool. Please, my dear, for the MRCOG exam, you have to be familiar with that. So what are you going to do? Simply practice, practice, practice. When you practice cases like this, and you practice this with your friends, now you are over it, okay? You will, by the daily practice, you will be expert in it, right? So please practice the labor word, okay? And give it time as it's a module, because it takes one task out of the 14 tasks. You have 14 module and you have one task cover labor word, means that this is covering one module. If there is any missed information or that required for management, please ask about it, or you will fail safety. Make sure that you have covered all the component of the task. For example, don't spend too much time on management and skip the allocation, or even forget the prioritization at the end. Sometimes it happens. Okay, and what I'm telling you here from the advices is things that I have experienced with the candidate over the years when we, teach the part 3. In your plan of prioritization, saving mother life first, please. Okay, so if you have a case of bleeding, severe bleeding, right? Severe bleeding, and you have a case of pathological CTG, which one have the priority over the other? Both are urgent, both you need to deal with them, but which one, the bleeding case or the CTG, pathological CTG case?
Bleeding. Ma'am, bleeding.
Excellent. So mother life first. Thank you very much. So it's the mother life first, please, in your arrangement, okay? What you will face in the exam, you will find 2 to 3 emergencies, okay? And you will be sometimes confused which one to put first, okay? Simply, straightforward, put the one that have the highest risk on the maternal life first, okay? So please take care of this point. Then remember that you can't do everything by yourself. And this is again another common mistake by the candidate. I listen to candidate and all the time they say in room 1, I will go and see and assess. In room 2, I will go and see and assess. In room 3, I will do. No, you can't do anything. This is physically actually impossible, okay? And there are some cases there, they need attendance of other stuff. You can't work and cover everything. And if you did that, you will feel communication with colleagues and safety as well, both, right? Because you need to ask, for example, you have a case with episiotomy, awaiting suture. Send the midwife, right? Why do you think that he mentioned that this midwife can stitch episiotomy? Yes, please send the midwife. Case need assessment. She is in labor and she need examination. Other than the pathological CTG, okay? Another case in labor. Send the midwife to assess her. This is the job of the midwife, to assess women in labor, okay? You want to know the vital signs and examination of one case. Send your SHO, right? He can do it. He can do vital signs and examination, okay? General examination of a case, right, my friends? So whatever you have from the task that's not life-threatening, okay, at the moment, send one of your colleagues. And if you require help from other colleagues, like your consultant, please don't hesitate to call for the consultant to come and help you for this case. Okay, my friends? Trust the midwife again. This is related to the point 12. And in any obstetric emergency, this is yours. So sometimes you will be a little hesitant, okay, which case to choose. There is one case of eclampsia, postnatal eclampsia, and there is one case of pathological CTG. Now I want to attend this case. Who's going to attend the case of the eclampsia and who is going to attend the case of the pathological CTG?
Eclampsia anesthetic registrar can go along with the...
Yes, yes, thank you very much. So the anesthetist is well trained in manage emergencies, okay, like this. So the anesthetist can attend this case and you will go to the obstetric case because you are the obstetrician, right?
Dr. Rabba, can I ask one question?
Yes, please.
Yes, ma'am, like the 2-3
Yes,
emergencies
dear.
are there. Hello, ma'am? Hello? Hello, ma'am, my voice is clear?
Yes, my dear.
Okay. Ma'am, I want to ask like some
Yes,
2-3 cases emergencies are there, so like some placenta previa is there, intra-abdominal bleeding is there, and also pathological CTG. Some more also emergencies. So in the labor ward, all the 3-4 emergencies are there. So where we should go and where we arrange a consultant?
2, yes, of course. If you have 2, this is what we are just, saying in the point number 14. It's if 2 obstetric emergencies are there in the same time, okay,
Yes,
call the
yes,
consultant to cover one, right? One case, let's say third case need maybe, okay, pathological CTG, and you can send at the moment, okay, because you have another case of severe bleeding. You can send at the moment your ST2, okay, to assess the case, review the CTG, and start conservative management and let you know what is happening, right?
Okay,
So
ma'am.
this is for example. So in obstetric emergencies, you have to, the most urgent one is yours.
Okay.
This is the rule. Why? Because you are the one on the floor. You are the one now nearest to the case. The second for the consultant. Okay?
Dr. Abba?
Yes, it's
Thank you, ma'am.
yes, dear. Yes, my
Even
dear.
if it is a preeclampsia antenatal, like patient is still like not delivered, so we should send anesthetist or we should go by ourselves.
One of the team, okay, one of the team for the management of eclampsia, okay, is the anesthetist, okay, okay. So if I have, yes, if I have another woman dying on the same time, okay, look, my dear, two
Okay.
ladies are there. Usually, I will go to any case of eclampsia in the antenatal care, of course, okay, but I have another one with severe bleeding, atonic postpartum or uterine inversion or whatever. Okay, so now two are needed. Okay, so the anesthetist can go and inform your consultant to go as well, and you go to the obstetric one. Let's say this is the only, or this is the top emergency in my on my board. Okay, I will go with the anesthetist because it's antenatal. Why? Because there is decision for labor need to be taken, and also I will call my consultant to come and join me, right? Because it's a big case. Okay, postpartum you will attend. Yes, my dear, postpartum hemorrhage you have to attend, guys. You guys, don't please, okay, assume scenarios without seeing the full board together. Why? Because my friends, it's usually, okay, it's balanced. Any labor word, it's balanced, okay, and there is rule for everyone, and there is no wrong, okay, like problems. Sometimes you can think that, oh, I have two emergencies in the same time. What is the solution? Which one to go for? No, you don't need to go for the both at the same time. One, your consultant can help you in, and the other one is yours. Okay? One, I can go now and I can call my consultant to come in 10 minutes and see the case. Like, for example, category 1 cesarean section, and another one with mother unstable. So I can go to the mother, the unstable, and the cat 1 cesarean section need to be done in 30 minutes. And if you know that the consultant must, reply the call, okay, and attend the case within 20 minutes. Okay, so that's mean that the consultant will be on the way, okay, to perform the cesarean section, right? Yeah, means that you will inform the coordinator midwife, they confirm OT stuff, inform them, okay, prepare the patient, and you are managing the unstable patient while the other one is being prepared, but prepared not by you. You can't do everything in the same time. Someone else is doing the job, okay? So I have two cases, one postpartum hemorrhage severe, and the other one is eclampsia. Two emergencies on one board. Oh my God. Yes, it can be, but postpartum hemorrhage, I will go myself, right? If it's severe, okay, I will go myself, and the resuscitation team, including the anesthetist, even the anesthetist consultant can go, okay, for this case. The anesthetist on call first will go, inform the consultant and alert them about the emergency, okay? So do you think that the anesthetist will not be able, with a midwife and the SHO, will not be able to manage a case of eclampsia? Give her magnesium sulfate, they will be able to manage, don't worry about them. Okay, guys, they are well trained. I hope that you have seen the prompt videos. Have you seen the prompt training?
Yes, doctor.
Yes, in the prompt training, it was beautifully, the rules of everybody was beautifully allocated. Okay. So if you have a case waiting in the A&E, who can see the case in the A&E?
ST1 can go, and take the history.
SHO, yes, excellent. SHO can go for assessment and take history and maybe request some basic, investigation. Okay. Any case of
Doctor.
preterm, yes, dear.
Doctor, if the A&E case is an urgent case, do we attend the case first or we attend the labor room case first? Example, the A&E case is like ectopic pregnancy or patient is unstable, so we couldn't send the ST1 to review the case. And at the same time, we have the eclampsia or postpartum hemorrhage in the labor room. So we attend the postpartum hemorrhage and send the consultant to A&E or how?
Again, it's according to what you have on the board, right?
So we still take the A&E case as a urgent case, right?
Of course, if it's urgent, it will be urgent, right? But the A&E case is within a safe hand. You know that?
Or it won't be a urgent case normally in the exam.
The A&E, there is A&E staff, okay? And they are well in managing and stabilizing patient, right? If you have a call from the A&E, means that they are worried about one case, can send the SHO to take, the clinical picture, do examination, okay? And maybe he will inform you over the phone what is going on in the case, right? While you are in the theater managing other emergency, right? So you're just not sitting there waiting for the case or the SHO to see the case. You are managing a top priority case, right?
Okay, understand. Okay, doctor.
You're welcome, dear. This is what I'm saying, my friend, that we can't do everything ourselves. Okay, so my friend, what about the preterm? What is required for any preterm case?
Ma'am, we inform the neonatologist. We ensure about the cot availability. We do the ultrasound for the fetal well-being, presentation of the baby, and also steroid cover, magnesium sulfate if she's in advanced labor, GPS prophylaxis, and tocolytics if she's not in advanced labor.
Yes, well done. Okay, so that's very basic, for the preterm cases. So it's correct. Okay, sometimes the preterm cases comes with PPROM. So, for example, the management of the PPROM will make a little bit difference in like assessment of the
chorioamnitis we need to rule out in that cases.
Yes, excellent chorioamnitis. You offer the antibiotic, and accordingly, you inform the consultant, of course, about the case, informs the neonatologist, and check the availability of cot, everything. But one thing that I need you guys to always remember in the preterm cases, that counseling to the patient is very important. So you have to say that you are going to communicate with the patient. You're going to counsel the patient and the family attendants, okay, about the outcome. Yes, so they will be ready for it. Okay, my friend, it's part of the communication, assessment of the communication, also safety for preterm deliveries. Now we come to another very famous, situation, like undiagnosed breech, for example, that's need ultrasound and counseling for mode of the delivery, and the counseling is your job. However, the ultrasound is not always your job. So if you have another emergency, yes, I know that counseling is your job, okay? Yes, I know this. And I know that, for example, that and you need to counsel the case yourself about the mode of delivery or about the options that she have. You want to go for a case that is angry, for example, for debrief. But is it now or after I finish the top emergencies?
After we finish the top emergencies.
Yes, this is what is called the triage principles. Okay, so cases now in triage, and by the way, there is one scientific impact paper being published by, good practice being published by the college about the maternity triage. Okay, and in there, they were giving advices regarding the time of management and how to deal with the cases. Is it top urgent cases, so it will take the color red, and if it is less urgent, okay, or can be attended within, like, for example, 2 to 6 hours, for example, okay, then it will be like amber. And if there is one case that is cold, it can wait, then it will take in the triage the green color. So it's according to the triaging of the cases, right? So yes, the workload is so much, there is shortage of the staff, and this problem is all over the UK. And what you can do is to be a safe doctor, that you can prioritize the cases. You can go to the top emergency, identify the top emergency cases and go for it first. Also, you can allocate the staff or delegate the staff to the other urgent cases, okay? So they can manage them or stabilize them or provide first aid for them, or some steps in the management for them while you are managing another emergency. And then you will go to the other rooms, okay, one by one. So I don't want you also to say in the exam, please, that first I will go to room 4, then I will go to room 3, then I will go to room... No, please don't say that, okay? Say the prioritization. The top priority is room 4, okay? The next, okay, is room, for example, 5. Room 6 is also urgent, okay? But it can be in the third priority, okay? So this is what you need to say to the examiner. Please don't say, I will go, I will go, I will go. Right? That's mean, you know what is the translation of this to in English? That's mean, I will leave this case. After finish the case number 1, I will go to the case number 2, and then I will go to number 3. So everybody will die in your duty, right? So please, guys, take care, okay, of the cases and what comes out from your mouth, okay, when you speak to the examiner. And the rules is very important. Understanding that we can't cover everything in one time. We can't, provide the care myself, okay? Have to work in a team, and the team, everyone in the team, they know their own roles. That will be great. This is what's required from you. In any active bleeding case, please remember, especially if it is severe bleeding, of course, that will be the major obstetric hemorrhage protocol, and you need to notify the team, including labs. Also, don't forget, please don't forget that in any management of any emergency case, remember the ABCs, please, okay? People tend to forget the ABCs. They forget that the airway first, breathing and circulation comes second, and then they, for example, the delivery or the specific management of this emergency. People forget that. Can you imagine? So people forget to offer, for example, for a case who is acutely unwell, they forget to provide oxygen first. They speak about the OT, they speak about the going to surgery or going to theater and blah, 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 and they forget the basics. Okay, so please be careful when you speak about the protocols, and whatever protocol you have to apply it as it is, to go with the same sequence. We have protocols, okay, in our curriculum, or in our practice. We have like what? Like one is maternal collapse, one of the cardiac arrest, one of shoulder dystocia, one of the major postpartum hemorrhage, antepartum hemorrhage, eclampsia. Please go through the protocol as it is, okay? From the ABCs, stepwise, okay? Don't jump. Okay, my friends, okay. For any case that is actively bleeding, don't forget the basics, like saying that, yes, you will see the ABCs, assess the vitals, okay? Blood sent to the group and cross match, 2 large bore cannula for the circulation, and start the medication along with warm fluids, assess the blood loss, and treat the cause, okay? So while you are saying that, okay, while you are mentioning that, just try to go stepwise, okay? Any case of Preeclampsia does not deliver yet. That's require a rapid assessment of vital signs of impending eclampsia, PRH profile, start medication, assess decision for delivery. And number 20 is don't overmanage the cases. Please don't overmanage. Why? You will see now you have like 9 tasks on a board, and you have 9 minutes, let's say, for the management. The prioritization is at the end, okay? Introduction and management and allocation of staff, categorization as well. This is all should be done in 9 minutes. That's mean that you should spend in some rooms less than 1 minute, and in other room maximum 1.5 minutes. Okay, so you can't really exceed that. And the 1.5 minutes, that's only for the top urgent cases. Otherwise, other cases should be finished in less than 1 minute. In less than 1 minute, you're required to give me a safe plan. Imagine. That's mean the management on the top of your mouth. This is one thing. Another thing is that you don't exceed the immediate management. Don't speak about further. Don't speak about future so much, okay? Just speak about now. So don't say, for example, a case with suspected delay in the first stage of delivery. Case of suspected delay, what the guideline says. Counter the patient about amniotomy if the membranes are intact, okay? And give her further 2 hours, okay? And then repeat assessment by abdominal and vaginal examination, right? This is what the guidelines say. Can I just say, and I will see after the 4 hours, if the contractions are not adequate, then I will think about starting oxytocin. And for the oxytocin, I need epidural, effective analgesia, and the best is epidural. And if there is no progress after 4 hours, I will take her for cesarean section for non-progressive labor. If the CTG is normal, I will take her as category 2. If the CTG is changed or pathological, then I have to stop the oxytocin and I will go for cut 1 cesarean. Can I say that? Can I do that? No. It's completely wrong. And people who are very good in studying and they know, mashallah, so much, are very knowledgeable, they tend to do that, unfortunately. Okay? Why? Because they have so much knowledge and they want to skip it all, you know? So they want to say everything. No, you can't say everything. Unfortunately, this is only a 10-minute task. Okay, so one of the point that you have to make sure you are capable to do it is the time management. Okay, so my friends, I hope that the advice is not so annoying. Okay, and I hope that you can apply it in the next task. And who is my first? I think it was Dr. Ong, I think.
Yes, doctor.
Okay, so my dear, okay, and who will be next? Because you will do half of the board only. You will do the first 4 cases in the board. Then your friend, okay, so Dr. Rika will be next. Okay, so my dear Dr. Ong, now your job is that you read the task both with Dr. Rika. Please read the task with her. And then you introduce yourself, go to the 4 rooms. So that's mean you will go room by room, okay? You must go now, room by room in our practice now, okay? Then Dr. Rika will take the next 5 tasks, okay? And at the end, Dr. Rika, she will be requested to do the prioritization at the end. Okay, guys? Okay, so Dr. Suzanne can start the next task, my dear. Now, Dr. Unga and Dr. Rika. Dr. Tanya can do with Dr. Suzanne. That's great. So we have the 4 of today.
Ma'am, next one.
Okay.
I will do next 5, ma'am, isn't it?
Doctor, I will do first 4, is it?
Dr. Ong will do first. Then Dr. Rika will do the second part. So Dr. Ong, you are required to cover the first 4 rooms. Okay, until Sana. Sana is yours. Then Dr. Rika, you will take from Tracy to Talia. Okay.
Okay, I got it.
Okay, thank you. Okay, so 5 minutes for every one of you guys, for each one.
I start, right?
Yes, please.
Okay. Hi, I'm Ong, one of the Part 3 MRCOG exam candidate. I'm ready for discussion.
Okay, so now you can see the board, and in this board there is, as you can see, 9 cases. You'll be required to cover 4, and for each case, you have to do plan of management, delegation of the task, and prioritization at the end. If you require any further information, please let me know. I will give it to you. I will hand it to you if it's available.
Okay, so for the first case, Sadia, she's primary with the background history of known case of sickle cell disease, come in labor with contraction 3 in 10. So I will assign ST1 to attend this case as this is a semi-urgent case, and I will involve a multidiscipline team which involves senior obstetrician, anesthesia, hematologist, and also senior midwife to see the patient. I will make sure the patient is kept warm and also have adequate fluid during the labor. I also will monitor the fetal heart rate by continuously, and also in this case, if the patient require pain relief, I will try to avoid petidine, and if we will monitor the labor progress. If the labor is not progress, we will counsel the patient. There's a risk of consider lower segment, which are cesarean section. So for the next case is Katie. She's 34 years old with morbid obesity. And then she is post-delivery with complicated with postpartum hemorrhage and uterine inversion. This is urgent case, so will be attended by me, ST5 with as anesthetic registrar. So I will go for, first of all, I will inform obstetrician and anesthesia, alert hematologist, alert the blood transfusion laboratory, and also alert the consultant obstetrician. I will go for ABC protocol. And first of all, I will start with oxygen mask, and then I will insert 2 large bore granula and send for the blood for full blood count, coagulation profile, liver function test, renal function test, and standby for cross-match 4 unit fresh frozen plasma, platelet, and also cryoprecipitate. And in this case, I will also assess the consciousness of the patient, and I will start free resuscitation for 2 liter of crystalloid and then 1.5 liter of colloid. And then I will do also assess the vital sign, blood pressure, heart rate, respiratory rate, and also SpO2 and temperature. And then I will move on with abdominal examination and vaginal examination to confirm the uterine inversion. And I will try to attempt menorrhea reduction. While doing the menorrhea reduction, I will stop the oxytocin. If it's failed, I may need to proceed with surgery. And then after then we will need to prepare to send the patient after taking the consent. And then I will debrief and document the event and also do an incident reporting and cover the patient with antibiotic. So next is Dara. She is primary, is a DCDA twin in second stage of labor. First string is delivered, second string is breached with a normal CTG. However, or is already delayed in delivered in the second twin, so it's also urgent, will be attended by my consultant with a pediatrician on board. And also I will do a ultrasound to confirm the location of the placenta and the position of the baby to see whether it's flexed or extended. Then continuously of the monitoring of the CTG is there. And I will also do a pelvic examination to confirm the cervical dilatation, effacement, and position of the membrane. And we will counsel the patient regarding the pro and cons of breech delivery versus cesarean section. And then if the patient willing for vaginal delivery, we will monitor the progress of the labor and also the fetal well-being. If the patient willing for cesarean section, we will counsel the patient regarding the risk of the cesarean section, prepare for the OT, inform the theater staff, and also anesthesia. So next case will be Sana. She's para 2 in second stage of labor with suspicious CTG and meconium stain like Hua. So for this case, will be semi-urgent, will be attended by my ST2 and also midwife. And then I will ask her to do a abdominal examination, and also do a vaginal examination to know the cervical dilatation, effacement, and also the position of the baby. And since the CTG is suspicious, we can do an initial conservative measure like hydration and also left lateral position.
Okay.
Sorry, not enough time.
No worries. Marika, please continue.
Okay, Tracy, postnatal patient with a severe preeclampsia, and her current blood pressure is 160 by 100. I would like to know that what antihypertensive she is receiving, and her clonus, reflexes, and either her PET profile was sent or not.
Yes,
Hello?
it's sent. Yes, it's sent.
Okay, so I will, it's then a semi-urgent case for me. I will send my anesthetic registrar here. He will going to continue the Mayo's observation and may offer her the antihypertensive after excluding the allergy. Oral labetalol will be given. Continue with the magnesium sulfate and also pain relief will be discussed with the patient. And my next case is patient is para 2, 41 weeks. She is in the second stage. She is pushing for the 90 minutes, Julia patient. So here I would like to know about her observation and CTG for the contraction and fetal heart sound, and how much she is fully dilated, so stage position and any capit molding.
No. The case now is +2 and there is minimal caput and no molding.
Okay, so she already pushing for the 90 minutes. So it's an urgent case for me. I will be once I get free from my other rooms, emergency rooms, I will send meanwhile the ST2 here. She will going to observe the patient and she will ensure that the patient is having the pain relief, and then the second then the forceps will be applied in the labor room after taking the patient's consent and counsel her about that.
The baby? Okay, so do you want anything for the baby at the moment?
Yes, I mentioned the CTG for the fetal heart sound and contraction.
Okay, so you need CTG for this case.
Yes, I need.
Okay, so please go next.
Okay, and my 7 case is the patient Rama. She delivered and she's waiting for the suture. I would like to know about her observation.
She's stable.
Contracted.
She is stable.
So it is an second case. I will send my midwife. She will apologize for the delay and she will check for the type of the tear what she is having, and then she will stitch. If in case it is 3rd degree or 4th degree, then it will be stitched by me or my consultant in the operation theater once we get free from other rooms. Sarah patient, para 1. She's 38 weeks with the breech. Here I would like to know about the which type of the breech the patient is having and any contractions she is having.
We don't know yet about the type of breech, so how would you know?
So we do the bed. It's it's a routine case. I will send a midwife here. She will going to check her any risk factors she is having and review her, rule out any risk factor and check for the ultrasound for the type of the breech. And she is in the latent phase. If there is no any concern, so she can admitted in the labor ward once she is in the advanced labor. Then the CTG and the labor care guide will be started. We'll ensure about IV line, group and safe and complete blood count. My last case is Talia patient, a 38 weeks non-case of the diabetes mellitus. Here for the induction of labor, here I would like to know that the ultrasound for the estimated fetal weight, amount of liquor and current her glucose level.
Okay, so the estimated fetal weight is 4 kg and the blood sugar control is fine. She's
Okay,
on
so
insulin.
if it is a type of diabetes is type 1?
Yes, she's on insulin.
I will. It is a routine case. I will send my midwife. She will apologize for the delay. Once we get free from the other rooms, we will start the induction. We will inform the diabetic team also, and diabetes insulin infusion will be started. Glucose monitoring will be done. CTG will be done. Once we get free from the other rooms, and we check for the bishop, and CTG will be done before the induction. So in all the cases, the first topmost priority is the uterine inversion, room number 2. And then second emergency is the patient is with a suspicious.
Okay. It's your 5 minutes finished. Okay.
Okay, ma'am.
So it's yours. Thank you. It's your 5 minutes finished. So we have to stop here. Okay. And then we will do the prioritization together. Okay. But because we have to strictly perform in 10 minutes, you know the rule, right?
Yes, ma'am.
Doctor. I even forget the case 1 is all negative. When I go to the second case only, I saw it. But can we go back to the first case when we already go to the second case? Like
No, don't look at media. Okay, don't confuse yourself. She's still in labor at the moment, right?
yeah, so
And you have to provide her with the care necessary for the case of sickle cell disease in labor, right?
Yeah.
So the thing is that now she did not deliver yet, right?
oh, so even though I not mention about the group and safe wing for the blood or inform the hematology to save the, I mean, so it's not like mandatory in this
Yes.
point lah.
Have to complete
Okay.
it.
Yeah,
You have to complete the
I just
plan
realized
there.
when I go to the next case because I worried about the second case and the third case rather than the first case.
Don't do that. Just once you finish the case, go to the next, okay? And if you forgot something, you can explain to the examiner at the end. But just make
Okay.
sure that you go with the flow. Don't spend too much time in one task. Okay?
Yeah.
The most important thing is that tackle the important or the red lines of the task. There is some red lines in every task, and we have to tackle them, right? So some points, if you miss, okay, that will take away one of your marks in the applied clinical knowledge and safety. Like, for example, the patient who delivered. She's delivered now, okay? So it's so important for us to know about the baby blood group, okay? So we can offer her the anti-D, right?
Oh, yes.
But the case of antenatal, yes, she is antenatal. We will do another thing for the blood, but it's not about here, the anti-D, okay?
Okay.
The case that delivered, it's most important, okay? So it's a point of, they put asterisk in the exam for the point that if a candidate miss, that will mark the candidate down and they can change their score from, for example, pass to borderline or fail, right? So the point of the asterisk in the exam that we can't really miss.
Means we cannot miss the B negative give NTD prophylaxis.
Yes, we can't admit that specifically
Because it's a patient safety.
postnatal. Yes, specifically in postnatal. Okay, but for this case, you have to inform, of course, the hematologist and the blood investigation that you will send. That will include the group and save for her, everything. Okay, everything you have to cover. Yes. Okay, so my friends, I would love to comment on your performance, but if you allow me, okay, that's like 10 minutes for prayer and come back, if you don't mind.
Can,
Okay,
doctor. Okay,
Okay.
okay.
Thank you very much, guys. So 10 minutes. During this 10 minutes, hello, my
Yes,
friends.
ma'am.
Welcome back.
Hi, doctor.
Hi, how are you? Okay, so what I can see here, okay, that nobody have posted the notes or prioritization. However, I would like to ask you, my dear, how would you comment on your performance in this task?
My performance not so good. I think I miss a lot of things and I say something wrongly. And then like for the second case, I think I don't know whether I need to say to assess the perineal tear because it's a PPH case and also you try inversion. So I was a bit of like rushing to talk about PPH and uterine inversion at the same time. So for the twin delivery, I think I talk more about the bridge counseling rather than give the plain right membrane intact or not intact, then push the patient for internal podalic version, external podalic, external cephalic version or whatever. So for the last case, I think it's a or operative vaginal delivery, right, doctor?
Okay.
Mm.
Okay, so that's okay. Thank you very much. This was a good reflection, okay, on yourself. That's on the task. From what I have seen, okay, or listened to your introduction, and it was good. Okay, you didn't waste any time in the introduction, so it was a good, again, good. However, I would like you to mention, if you can add, please, that you will follow this part tool. Okay. And
Okay.
please try to follow the SPAR tool, really. How? It's simply by you mention, okay, the situation, if it is delayed labor, if it is a sickle cell disease in labor, okay, something like that. So if you practice more about how to present by the SPAR, that will be easy, okay, more easy for everyone. Okay, this is one thing. Another thing, that when you come to the background and you come to the assessment required, I will always remind you that assessment have two parts of the assessment. One part is the part of maternal, okay, and the second part is the fetal assessment, okay. So always mention about that you want to assess or to know about the fetal heart rate and start or recommend, as you said, for the continuous fetal monitoring, right? So here is some keys, okay, that's for the cases, the most common cases of labor ward and the most common emergencies that come. One of them here is sickle cell disease in labor, and let's see, okay, what is the recommendation, okay, for this task. Okay, so in labor ward prioritization, we can see part of the hematological disorders, okay, and the famous one is the sickle cell disease or sickle cell crisis, sometimes thalassemia or von Willebrand disease. Regarding the sickle cell disease in labor, it can be managed as the semi-urgent case by ST1 or ST2, okay? And that you have mentioned about the relevant multidisciplinary team, that's okay. Yes, you did that, so well done for that. The most important part of the multidisciplinary team is your senior, okay, and the hematologist, right? So this should be informed once the labor is started. The patient need to be kept warm, and part of this you have already covered, and given adequate fluid during labor. So well done for that. Continuous intrapartum electronic fetal heart rate monitoring is required. So you also, I think you have this part, okay, owing to the increased risk of fetal distress, right, which may necessitate even expediting the delivery. In analgesia, you have to keep also good pain control, okay? So for that, the anesthetist is here to help you, and we avoid the pethidine, right? If there is delay in the progress of labor or in the second stage, so we go for what? We go for the cesarean section. Don't let the patient suffer too much, because this may anticipate crisis. Regarding this patient, she had anemia, right? So what blood investigation will you advise for a sickle cell disease in labor? The full blood group, as usual, group and safe.
Cross matching.
Right? Okay, so if she is had delivered and she had postpartum, you will request the cross match for now, for urgent.
Otherwise,
Right?
atypical antibodies.
Yes, so it has to be tested, right? So it has to be tested. That's why you are calling the hematologist. So they will check, okay, the blood sample that you send, and they will prepare themselves in case of any replacement is needed, right? So you have done the case of the sickle cell disease. However, I thought that you spend a little bit more time than required, but it was fine because overall your time management was okay. Okay, so the next case, do you remember what is the next case? This is the case of the uterine inversion, right? Uterine inversion is one of the emergencies that comes, right, in our exam. So I have to be ready for the cases of uterine inversion. I have to be ready for the cases of retained placenta, right? And I have to manage the cases of emergencies also like cord prolapse. The 3 cases are required, okay? That and very common. Sometimes it comes also as an evolving scenario, by the way. Means that the case started by a case in labor, and then you will say that this case in labor, so if the progress is fine, okay, so keep the midwife with her, and so on. Then all of a sudden the examiner, while you are in case 5 or something, he will tell you that now the case in number 2 had delivered already, but while they are conducting the 3rd stage, okay, the uterine, there was a uterine inversion along with tonic PPH. So here, my dear friend, you have to mention what is the immediate management or the steps of the uterine inversion. Other cases as well that can come as evolving scenario like uterine inversion, retained placenta, cord prolapse. Okay, so please be careful of those cases and those emergencies, and you have to be ready for this. The uterine inversion is urgent case, and it's your case now. This is your obstetric emergency now with anesthetic registrar. You need to access the consciousness of the patient and confirm the uterine inversion by abdominal and vaginal examination before please going to the management of postpartum hemorrhage. In the postpartum hemorrhage, I need you to say the assessment because we have a SPAR tool, right? So the SPAR can help us to remember what is the points to ask first. Okay, for the assessment, I need to know about her vitals, right? I need to know about the estimated blood loss, right? So I can say, what type of PPH is that? Okay, is it a major PPH? Is
Neurogenic
it
shock.
a mild? Yes, maybe the patient, yes, the patient may be in shock because of the uterine inversion itself. So I need to mention about the consciousness level and the vitals of the patient, okay? And confirm the uterine inversion go down to the abdomen. You remember this funny drawing, okay? And she's delivered, so I'm not going to draw her abdomen very big. I will draw like this, okay? So this funny case is starting from the head to the toe of the patient, okay, of this diagram. So vitals, consciousness level, and go next to the abdominal and vaginal quickly, okay, because you need the assessment before you over management, okay? So this is the thing, that you managed before the assessment. So correct assessment, okay, is needed. So you will decide what is the level of urgency in this case. Stabilization, this is the management. This is the recommendation. This is the R in SPAR. Stabilize the patient with resuscitation and attempt manual reduction. Okay, of course, the oxytocin, if it is running, okay, you have to stop it, right? And here is the famous diagram for the management of the uterine inversion. So you will suspect, okay, the uterine inversion in cases when the woman in labor have unexplained shock during or following the 3rd stage of labor, and it can happen even with proper 3rd stage. Resuscitate and replace the inversion as soon as possible. Okay, the types of or the methods of the inversion of the replacing the inversion could be manual, hydrostatic replacement, or surgery is the last resort. Sooner, okay, the after the inversion is replaced is the better, of course. The sooner is the better, and then you can offer the oxytocin post replacement, right, and manage the postpartum hemorrhage as such. Don't remove the placenta, okay, if attached, please, until the uterus is replaced. So I need to act first, okay, for the uterine inversion, because you will never control the PPH without you replace the uterus, right? Can you do that? You need the replacement first. So the replacement again could be manually or by hydrostatic reduction or by surgery, or you know, you will do combination of these, if one method is not working, you need debrief documentation and incident report, and for that you have covered, so well done. Okay, and antibiotic coverage, yes, you did this. So yes, my dear, you have covered this emergency nicely. Okay, and this is regarding the uterine inversion, or even for the cases of retained placenta, you have to be ready also by the retained placenta algorithm.
Doctor,
Now,
do we need to, sorry, doctor, do we need
yes,
to mention the name of the surgery?
you don't need really, but you have to go for surgical management. Okay,
Oh.
let's remember we are managing one case in 1 minute, right?
Okay.
So I
Mm.
can't cover everything in the details of the
So
theory, but
one thing I
go
miss is
outside.
assess the blood loss. I miss the assess of the blood loss.
Yes, assess of the vitals and the consciousness and blood loss, it should be first before you offer.
Yeah, I assess the consciousness vital sign, but I miss the blood loss because I was like, oh, don't know what to tell at
Yes.
the point of the time.
No worry, no worries. Believe me, if you follow this part, that will help you. Because in this part, you will remember that this is the situation, this is the background of the case, this is the assessment that I need to do, and I need you to remember my funny drawing, okay, for the for the person assessment of head to toe. Head means that you start with the consciousness and you start with the vitals, right? If you need the chest assessment, you will go. If you need abdominal and vaginal examination, you will go, right?
Okay.
If you have a case, for example, of if pulmonary embolism, then you will do the assessment, yes, vitals, oxygen level, consciousness, everything, okay, and then you go to the chest, and then you go to the abdomen, you go to the vagina, you go even for the legs, because you remember, okay, in the cases of VTE, we need to assess the VTE, the DVT in the legs as well, part of the assessment, right? So
Yes.
just remember, put the diagram and remember what I need here to know. I don't need to offer everything. I'm not going to say I will check the blood pressure for every case. I will check the blah, blah, blah for every case. No, I will say what only necessary in this task.
Yes. Yes.
Now we come to the third case, okay, which is the very famous case of the twin pregnancy. Twin pregnancy in the part 3 can come as twin in labor, right? Twin in the second stage. One cephalic, one is transverse, one cephalic, one breech with prolonged second stage, which should be, by the way, should be delivered within 30 minutes. So this is a delay in progress, right? So very important point here is the CTG is normal. So this case need assessment, right? Assessment now for everything, like assessment of labor, right?
Yes.
Assessment, how well is the patient, abdominal examination, assess the contraction, assess the type of the breech, assess the engagement, and assess also the vaginal examination, okay? How is the situation vaginally, right? If the membrane of the second twin is intact or it is ruptured or whatever, what is the situation now, right? Then you suggest management based on that, okay? Who's going to help you in this case? Because the first case,
Examiner,
who can help you in that case?
midwife, consultant, and also senior consultant, and also a
Okay,
midwife.
so this case at the moment, okay, first you will give advice, right? That of course she will need to be attended by the experienced midwife in the unit. Anybody else come to see her? Yes, please. You need the consultant to come and assess, okay? Because twin pregnancy and breech, okay, you need somebody experienced, okay, to deal with this situation. If needed, okay, he can do the breech extraction, right? So who will do the breech extraction? Breech extraction is a procedure that is associated with high risk of complication. One of these complications can be vasovagal from the cervical, from inserting the hand inside. One can be the cervical trauma, right? One can be trauma to the fetus. So someone senior should perform this, okay? So
Yes.
who will do this? For that, you can call the consultant. So why didn't I call the consultant in the first case? No, the first case is your case. It's the top emergency. This is the case where you were running to it, right? Yes, the
Mm.
consultant can join you later, no problem. But if I have another situation that need the consultant management, okay, or the obstetric management, then my consultant should be there to help, right?
Mm. Yes.
Okay, so
Yes.
the twin scenarios. 1 second, my friends. I will only go back to these notes to show you that the possibilities of the twin scenario. Okay, so the twin scenarios, my dears, is what is the possibility of a twin scenario in the part 3? As I told you, one is in labor already. Okay, and for that high risk, it's high risk delivery and need to be attended by the midwife, need to be in an obstetric unit, and you have the CTG running. Okay, and if everything is fine, okay, it's and the first twin is cephalic, then allow the labor to progress. There is no problem in that, and there is no harm in that, right? But if we have a problem, a situation in the second stage, the situation of the second stage, my friend, is either, as I told you, you have one twin deliver and the other one is transverse. If it is transverse, in this case, you need to think about what? You need to think about the internal bodalic virgin, right? And
Yeah.
after that, what you need to think about breech extraction, because delivering as breech is always easier, right?
Yeah.
Okay, so the this is about the twin, okay, when you have scenario transverse. How about if the second is breech? Okay, for the second, you have to breech, you have to know if the breech is engaged or non-engaged, right?
Okay.
If the breech is engaged, what can you do here? If the breech is engaged,
Engage, I
and
will
you
And breech extraction.
breech extraction.
Yes, yes. If the breech is engaged, you have to do the breech extraction. Okay. So if it is abnormal fetal heart rate,
Caesar.
what you will do?
Assess the patient. If abnormal heart rate, doctor actually can go for cesarean section.
Depending upon the per-vaginal examination findings.
Yes, depending on the finding, if you can deliver by breech, or the consultant, I mean, can deliver by breech extraction, then it will be much faster than performing cesarean section, right? In cases of the abnormal fetal heart rate, right? So
Dr.
please
Radha, in
also
breech,
make
should
sure
we
that
offer the
the
ACV or
blood
not?
product are reserved for this patient and low threshold for the cesarean section. Yes.
Doctor, I want to ask question that should we offer external cephalic version in the previous scenario the baby was breech if not engaged?
If non-engaged, the consultant can attempt an ECV.
Okay.
But this will be individualized. This will be individualized only decision by consultant.
Okay.
Doctor, let's say
Okay.
if the labor ward during the examination, during the assessment, the examiner didn't give us any information, so we just come up with these 3 points. Let's say vegetarian, then engage. Or normally they were not telling us membrane intake or not, any fetal heart rate normal or not. We just mentioned these 3 points continuously.
No, usually, look, my dear, I can't really offer management without knowing the information in the A part. Okay, so the information in the A part comes from the assessment, and the assessment comes for mother and baby. So I need to know for the mother, okay, how is she doing, if she's well or not, and how the contractions, abdominal and vaginal examination, and this is one part. The other part is for the fetus. Okay, so I need to know about the fetal heart rate. If you didn't mention that,
Doctor.
Hello, your voice is not clear, ma'am.
Ma'am is left.
Okay.
I think it's a connection issue. Oh, coming back.
Hello, my friends. I'm sorry, this was internet drop from my side. I don't know why. So I'm sorry, guys. Nowadays, the Zoom is all of a sudden, restart itself. I'm sorry. Okay, so my friends, what we can see now, okay, as we say, that you have to apply this PARS tool. When you apply this PAR tool, that will remind you that in the assessment, I can't do a recommendation without assessment, right? Always, it's like this. Don't ever go to R without E. So in the assessment, there is maternal and fetal assessment. In the maternal assessment, you will remember the funny diagram, okay? And you need to do the assessment from head to toe, okay? This is for the mother and everything about the mother regarding abdominal examination, engagement of the breech, what the vaginal examination, membranes are there or not, and how about the station, everything, okay, will be mentioned here. In the fetus part, you have to, and the people always forget about the fetus if it's not given the information. If the fetal heart rate is not given, you must ask about it, right? Because twin in labor means that CTG should be there. So I need to know about the CTG, right? Okay, so here, my friends, if the CTG is normal, okay, so there is a window like 10 minutes or 15 minutes till the delivery be done, okay, or completed. That's the exact time where the consultant will come to you, okay? So it's fine. The consultant will come, will do assessment in view for, okay, either to go for breech extraction, this is what he will say, breech extraction or cesarean section. Right? Right? Because he will come and examine and assess and decide. Right?
Yes.
Okay. So now I have a blood product should be prepared. This is my job to advise blood product to be prepared. Full blood count and group and safe. At least you have a cannula, a wide bore cannula for this patient, any twin in labor, like any high risk case in labor. And I have low threshold for emergency cesarean section, and I need to inform the pediatrician, ensure that 2 cots will be ready for the 2 babies, okay, if needed. The twin, if comes as a preterm case, term twin delivery. Please remember that this is again your job. It comes from the ST4. From ST4 can attend the delivery of the preterm twin. Okay, so inform the consultant and the pediatrician. Okay, and assessment first, okay, you have to rely on the clinical management in the preterm labor or clinical diagnosis. Secondly, okay, you need to go for the continuous CTG, steroid and glycolysis if it is indicated according to the situation, okay, and in active labor, intrapartum antibiotic prophylaxis, like any case of preterm, right? But only check the availability of the NICU beds, okay, or otherwise arrange transfer and monitor the progress of labor counts regarding prognosis of preterm delivery for the babies. And this is part of the human communication that is needed to be covered in the cases of preterm twin. Okay, back to our list, and I hope that those bullet points helped you. Okay, and now we have case number 4. In the case number 4, what is the situation here? I have a situation of suspicious CTG plus fetal risk factor, which is the thick meconium stained liquor. Nowadays, my friend, what is the management of a suspicious CTG plus maternal or fetal risk factor? Can you please remind me of the new guideline?
Yes, ma'am. They are saying first you will make the urgent review by the senior midwife and check for any underlying cause, conservative measures, and then either the fetal scalp sampling or the expediting the delivery after the opinion of consultant or senior midwife.
Fetal scalp stimulation. Yes.
Fetal blood stamping.
Stimulation, ma'am.
Fetal blood sampling has been removed now.
Scalp stimulation.
Flow sample.
Scalp stimulation.
They are
Stimulation,
doing
ma'am.
fetal scalp
Or
stimulation,
stimulation.
right?
Yes, it is stimulation, not yes, it is stimulation. You just with sampling, so that's why I want to correct you. That's it. Okay, so
Oh.
yes, we're done, and I know that you know, but it just, you know, guys, it's a word slip from my tongue, no problem. Okay, so you will do this, okay, and you have to say that it's according to the background risk, okay, then you will decide either, okay, to continue on the conservative management or to expedite the delivery. Okay, so how would you know the background risk?
By assessment, maternal.
Excellent, excellent assessment. And in this case, I'll tell you guys, if there is a case in labor and I want to know more about the risk, okay, just mention one sentence. Say that I would like to know if there is any background maternal or fetal risk. Okay, so background maternal and fetal risk can save you here, can save your marks here. Okay, anyway, even if not, if there is no risk, okay, the actions that you have offered for a suspicious CTG now is good, okay? And I say that it's good because it's in line with the new guideline. The new guideline nowadays, my friend, have, you know, they have a change of the management. They have categorized the management of the suspicious CTG in two conditions. One says that if you have a suspicious CTG with
Without risk
maternal
factor.
or fetal risk factor, and he mentioned, you know what? Which point he mentioned exactly? He mentioned
Risk factor meconium, slow
yes,
progress, and sepsis.
yes, excellent. Okay, so the meconium, slow progress, and sepsis, okay, those are the examples that have been mentioned. However, this is not the only examples, right? So my friends, here I have to mention a stepwise approach at the same as in the CTG, okay, the new CTG, the fetal monitoring from the 2022, and I have to say that I need a full risk assessment, okay, and this is full set of maternal observation, taking into account the whole clinical picture and document the finding. Who will do that at the moment, okay, because the CTG is suspicious, okay, can be attended by experienced midwife, then you can go and assess the case yourself, of course, okay? Consider possible underlying causes, okay, and conservative measures as indicated. Don't please say routinely oxygen or IV fluid. It's now changed. Only oxygen if there is reduced saturation, only fluid if there is proof for, you know, dehydration. Otherwise, don't say it routinely. Say if it is indicated. Okay, left lateral position, of course, is advised for everyone. Okay, and if there is oxytocin, you stop the oxytocin, and then after that, we can consider either the fetal scalp stimulation, okay, and or expediting delivery. That's it. Okay, so now we go to the case number 5, and number 5 is postnatal case, okay, and the postnatal case with severe with preeclampsia. Okay, now what I need to do for this case, it will be attended by the midwife, right? Yes, one of the senior midwife and the middle grade doctor or the my colleague, the anesthetist, okay, registrar. So they will start on antihypertensive, right? She will receive one-to-one care in the high dependency unit and monitor of the observation, including the vital signs, the blood pressure, and the output, okay, the urine output. And if the PIH profile is not done, it will be done now and repeated after 48 hours. That's it, okay? So after you finish your emergencies, you have to go and review this case. Right, the top emergency cases, you go and review the case. Now we have number 6. So number 6 is again prolonged second stage. The prolonged second stage and pushing for 90 minutes. Again, what is the required? The required is full assessment. What is missed here? The most important part here that missed. Before I say recommendation, any recommendation, what is missed from this scenario?
CTG.
Progress.
Epidural.
Epidural.
Epidural, yes.
Epidural.
Okay, 1 second. First of all, I need to know about the fetal heart rate, right? So the fetal heart rate is very important. Okay, if the CTG is commented or
CTG.
not, Yes, 1 second, guys. So I
Ma'am,
want
when I
to
asked from you the CTG for the fetal heart rate, but at that time you said that CTG, or if you want to, you were agree for the intermittent auscultation. I didn't get your point at that time.
routinely any case, the case that does not have specific, because you will ask about background fetal and
Mm.
maternal risk. If there is no background and fetal maternal risk for all the labor, there is no need for CTG. But CTG can be indicated when there is confirmed delay of labor. Okay, because at that moment the management of
So we can ask ma'am in the CTG in this case, na?
you can ask, but after first
Okay.
you know what is the situation now.
Yes.
Right? You need to know about the situation. So this is one of the questions that you must ask before you suggest the management. Because if the fetal heart rate is bradycardia at the moment, then you turn the case into another acute emergency, right?
Yes, I asked, but yeah, I asked this. Yes.
Yes. So first we ask about the fetal heart rate because we know that it's missed now from the assessment, and I will give my recommendation as you have said. Okay, that's about full assessment of the case and assessment for what is needed for the next step in the management. The case is multi-para. Okay, so this is a confirmed delay, but still because we have there is some time for the assessment and for assessing the situation. Okay, while you are managing the other emergencies, you can come back and review this case or your consultant. So once finished from one of the emergencies, you can go to it. So delivered SVD awaiting
Dr. Abba,
sexual
can we
healing,
say in this case that she needs a operative vaginal delivery?
you will assess in the view for need for operative vaginal delivery or cesarean section according to the assessment.
Yes, as
Right?
you mentioned, stage +2 in this case.
Yes, yes, yes,
Okay.
of course. Yes, you asked me about this, the vaginal examination, and I told you you were correct. Also in 7, and you were correct also. Yeah, I want you to prioritize. This is the part that you missed in the first presentation in the 5 minutes. Would you please tell me what is your prioritization now?
Yes, ma'am. First case will be uterine inversion. It's my first priority because it's an emergency. Then I will take room number 2, and then room number severe preeclampsia, and then prolonged second stage. Then sickle cell disease after that twin.
Please mention
And
the room. Please mention the room.
first is room number 2, uterine inversion. Then room number this one, ma'am, suspicious CTG thick meconium, room number 4. Then room number severe preeclampsia, room number 5. And then twin, room number 3. And room number 1, sickle cell disease. After that, these low risk cases are 7, 8, 9.
Ma'am, can I try also?
Yes, please. Okay.
I will divide into urgent, semi-urgent, and also routine. Urgent will be labor room number 2, then labor room number 3, and then after that I will review labor room number 5. So semi-urgent will be labor room number 1, labor room number 4, and labor room number 6. Others all are routine. 7, 8, and 9 is routine. Hello?
6. Okay, so the case number 6 comes to you as semi-urgent.
Semi-urgent. Depend on the fetal heart rate.
But it will be urgent, I think.
Okay.
If
It needs to be
it's
urgent.
delay, so I think maybe if delay fetal heart rate is abnormal, is require operative assisted vaginal delivery, it will be urgent. If because it's delay, I think it's semi-urgent.
Okay. Okay. So you have said that it's a semi-urgent. Okay. You know what the meaning of semi-urgent in the categorization of cases? That's mean you can attend it in how many hours?
Or 1 hour.
Mm,
Itu. Don't know.
You will perform a CT if you will perform a cesarean section for this case. This cesarean section will be which category? According to the fetal heart rate, it could be the 1 or 2, right? So
2.
yes, according to the fetal heart rate. So this will be 2. That's mean you will need to attend this case. Okay, it's like within 1 hour, right? It's one of the urgent cases. Okay,
Oh.
that needs attendance, right? Because you need here, okay, assessment by a senior person, right? But the thing is, which case, I don't say that it's not urgent. I don't say that we will leave it, okay? But I have to go to the top emergency cases first, okay? I can say that this case, number 1 is 2, and the room number 2 with the uterine inversion, this is the everyone agree for this arrangement, right?
Yes.
Right.
Yes, ma'am.
Okay. Yes. Okay. So now, next, which one comes in the severity? Is it, I'll give you 2 choices. Is it 4 or 5?
4.
4.
Okay. So 4 or 5 again.
4. 4.
Even if you're not going to attend the case yourself.
5. 4, ma'am.
Okay.
4.
Yes, it's 4. It's 4. Okay. It's 4 plus 5. They can be done in the same time because one person will go to 5 and one person go to 4.
Yes.
Right? So in the second
Yes, ma'am.
priority, you will say 4 and 5. Okay? Okay. Then which case will come?
Yes,
The cases of delay. The cases of the delay, they both have the same level. Okay?
Yes.
One have the second is breach, but for 35 minutes, and the other one, he is pushing for 90 minutes, and she is multipara. So both will need also assessment, urgent assessment by the obstetrician, but it will come as a next priority. I can finish one case myself and go to the second, right? My consultant, they can finish one case and go to the second, right?
Okay.
Right? That's it. So that it's according to the priority. Let's say, is it something that it's fixed, or if you change the prioritization between, like, for example, one person said 4, 2, and then 4. One person say no, 2, 5, 4. Okay? Will that make a big difference for you in the exam? It will not
No.
make a big difference for you. Okay? Because you said it's urgent and you said it need immediate assessment, okay? And you said you send some person for it, okay? So it's fine. The case is safe. But what will be the big problem? The big problem is that you did not, catch the risk in the case and you didn't deal with this risk, okay? So if you're not aware, risk awareness, and you didn't manage this risk or offer a plan to manage this risk, this is failure. Okay. Otherwise, you identified what is the risk, and you have, you had a plan for that, and you have, put that on the top of your management, or you put that on the list of doing this case, and this case, and this case, then it's okay. Right, my friend? If I said, for example, for a case that is, she is known case coming for induction, known case of diabetes coming for induction. If I said about this case that this is urgent case or semi-urgent case, this is wrong. Okay, so this is a clear wrong. If I said, for example, that I will take the case with breach, low risk, before I say that I will take the case that delivered waiting suturing, can this be possible? No, this will be a big problem. Okay, so unless you didn't have a mistake in that, you miss the urgent cases, or you miss the management of the cases that need immediate management, okay, you are safe. Okay, guys? It doesn't matter also if you said 7 before 8 or 8 before 7. Okay, because both are non-urgent cases. No, sorry, it's not here. I mean, in 8 and 9. Because both are routine cases, non-urgent cases, right? So both can wait. Is that correct?
Yes, doctor.
Yes. Okay. Okay, my friends, so the next, thank you very much for this extensive discussion of the labor ward number 1. And here we have the list.
Doctor, in the last 2 cases for the induction of the labor and diabetes, we don't go into the details of that.
Don't go for the details, no. Just, ensure that the case is seen by, or the diabetic team is aware about her presence. The midwife will go and she will apologize for her or explain to her the situation in the labor room, apologize for the delay, check the fetal heart rate, okay? And, okay, nothing
Yes.
more that's
Doctor,
required. Thank you. Yes.
Doctor, just one question. Can we, before we start the next labor room, can we just ask the examiner any information added, any information provided before we start the task? Can we ask this question?
No, I'll tell you, the examiner will not answer this, okay? Because the examiner, he doesn't want you to be smart, to play smart. The examiner wants you to play safe, okay?
Oh,
So
okay.
in every case, he will be waiting for your assessment, your way of thinking of the risk in this case. And when you request a specific information about the case, he will understand that you are a safe doctor. When you miss this information, he will deduct you. He will take away mark from you. Why? Because you missed a safety in this case. So I can't say that there is like collective management. Some people will say, I will go check all the patient for anti-D requirement. I will go check all the patient for this. No, I can't say that.
Allergy.
I
Yes.
can't say that because simply I'm trying to play smart now. I'm not safe, okay? And there is nothing called all patient assist for what, okay? No, I will assess every case one by one, and I will provide management plan for each case one by one, okay? Each case according to its situation, according to her problem, right?
Yes. Okay.
You are
Thank
welcome.
you.
So, my friends, you are almost past the previous station. You did well. However, it can be better. The time management need only 1 more minute, okay, in the management. So please take care of the time management, guys, so you will be able to offer the correct prioritization at the end. Now, I think we have Dr. Suzanne.
Yes, doctor.
Hello, Dr. Suzanne. You are required to perform the 4 rooms, the first 4 rooms in 5 minutes, okay?
Okay.
You still have the ST2 and the ST1, okay, with you and 6 midwives. So the same stuff in the first task, not changed.
Okay.
My dear?
Hello.
Yes, please.
Okay. Hello, I am Suzanne, ST5 on labor room. I will go room by room. Then I will prioritize urgent, semi-urgent, and routine. So case number 1, room number 1. She is a patient for VBAC. In her background, she is 38 weeks and 5 cm. At 5 a.m., she is 4 cm. Intact membrane and fetal heart rate is okay. So I want to know about her vital signs.
Vitals are stable.
She is stable.
Yes.
About her, okay, about her, is there is any other risk factors in her or age?
No, I think this is what you have.
Okay, so any tenderness in the scar?
No, Dr. Suzanne, please don't await the answer from the examiner. Just mention what is there.
Okay.
Okay, I'm assessing this case abdominally for this and that.
Okay, okay.
So
So I
say
will
it
assess
while
her
you're
for tender.
thinking. Yes, please. Yeah.
Okay, I will assess her generally for stability, and then assess her abdominal for tender scar. Assess her CTG for the baby, and if everything is good, I will inform my consultant about this case. I let my midwife to continue her observation and update me with anything new. For the second room, this is top priority here because she is in career 90s. She had in her background is 28 weeks. So I want to assess her stability. She is she had fever now, and so I will call for help, inform the neonatologist, and start the six bundle. Give her 3 and take from her 3. Give her IV fluid, oxygen, and antibiotic. Take from her the culture, blood sample, and urine output. So this will continue. I will go for this patient by myself to stabilize the patient and continue her management after I inform the neonatologist about her. And shift her to HDU. Then the third patient, this is delivered already. So now she is waiting only for the suturing. I want to ask about her stability, and this is degree is of the tear. Is this any bleeding or any ongoing bleeding? Because she
Yes,
is a Jehovah's Witness.
yes, the patient is bleeding right now, and the estimated blood loss is 1,000 ml or more.
Mhm.
Her vital
Yes.
signs are 90/60 blood pressure, and the heart rate is 115.
Mhm. So her she's post-mortem hemorrhage now. So I will send the anesthesia doctor while I'm in the first room. The first priority is the second room. The anesthesia doctor to stabilize the patient. Start the BBH protocol in the hospital. Lead my midwife to inform the consultant to be here soon to manage the patient while the anesthesia doctor, the anesthetics manage the patient, stabilize the patient. And she is a Java witness, so we need to inform the blood bank and take the consent for other blood products. As the first case, this is the second stage, 30 minutes now. She is she had any I want to ask about her stability and if any risk in this patient.
No.
Her CTG is stable, normal.
Yes. Yes, fetal heart rate is normal. Yes.
Okay. If she the cervical dilatation,
She's in active second stage.
so
what
the
do you need
station
to
of
do
the baby.
for her? Yes. So what do you need to do for her? Please tell me.
Continue
It's not that fetal heart rate
observation
is
if she
fine.
is not delayed.
It's your
So
time.
I want
It's your time.
continue observation
Your
midwife.
time. Okay, so it's your time. Yes, thank you very much. Okay, so this is your time. So we need to work more, Dr. Suzanne, about the for the time management, please. Thank you very much for the presentation. Again, time management. So I'll tell you some tips if you allow me. For the task number 1, I have noticed that you're repeating what's written there. Okay, this is not required. So save your time because you spend, for example, at the beginning, like 30 seconds repeating what's written there, which means that it will let you at the end, okay, not able to finish your task. So what I have here, it's VBAC in labor. That's it, right? This is the situation, VBAC in labor. If you want to say VBAC in first stage in labor, that's great, okay? So what you need to know more about this case, okay? So this is enough. This is an obstetric risk factor, right? So she's already now high risk. So I have SPAR, okay? First stage of labor, previous cesarean section, and I want to perform assessment of the case. Assessment of the case, that include her vitals, okay? What is the vitals, patient well or not? And what is the abdominal examination, assessing her abdomen for the frequency of the contraction, okay, for the presenting part, for scar tenderness, okay, and then going to the vaginal examination. This will be due, okay, just say this was at 5 and now it's 8. This will be due in 1 hour. Who will do that? This is midwife, okay, an experienced midwife can perform the vaginal examination and the commence CTG. Send, okay, blood for this case, because any VBAC in labor, you have to send the full blood count and group and save, and make sure that you have a cannula. Right, my dear? And her progress of labor should be on a partogram, right? Or document the examination finding on the partogram. Then move to the next, okay? We don't need anything else. You prepared this patient, make sure that the patient is prepared, okay? Make sure that she will get the examination on time and the blood is sent and the CTG is started and partogram is there. I don't need anything more, okay? Then move faster to the next. Why? Because the next looks like your urgent case now, right? So I have one case, which is, she's a preterm, right? And she had PPROM with fever and offensive discharge. So I will say what is my diagnosis. So I will start by saying a case of chorioamnitis, mostly due to the prolonged rupture of membrane, right? Okay, so this is the situation, this is the background, right? Okay, and preterm. What you need to know now urgently is the assessment, right? And then the recommendation. Urgently is the assessment, and the assessment have 2 parts. Baby and, here her abdomen is because she's 28. Okay, so baby and mother. What about the baby? Okay, of course you need to know now immediately what is the fetal heart rate, right? Maybe the baby is dead, you don't know. So she's 28, you can even start, the fetal assessment afterwards, after stabilization of the mother. It can go by CTG afterwards. But now at least you need to know about the fetal heart rate. This is one thing. Another thing is for mother now, focus with the mother. Mother, I need to know exactly the vitals. Oxygen, including oxygen saturation, right? And start, please, the ABCs. Okay, always when you have a case that needs management, urgent management, don't forget the ABCs. ABCs means that you need to ensure that you have oxygen, okay, and if IV fluids, if there is a drop in her blood pressure, okay, and usually they will need IV fluids in case of fever, also that will help the temperature, okay, and you will start to mention about the 6 bundle, okay? The 6 bundle, as you said, okay, the steps of the 6 bundle was fine. So you offer the oxygen fluids and you take the, send the labs for the blood culture, okay? Urine also will be sent usually for all the cases of preterm or PPROM. You can take a swab as well because of offensive discharge, okay? Send all of this to microbiologists. You can take even the microbiologist's opinion, and you can start a broad spectrum antibiotic after excluding allergy, right? And the urine output will be monitored and lactate to be measured, and the patient should stay in the high dependency unit. Okay, so at the moment, okay, who can manage this case? You wanted to go yourself at the beginning, right? And who else will help you in that case? You informed your consultant, you informed the neonatologist about the situation, and also for the availability of cot if there is need for delivery. And
I
who's
said
else?
that in call of help.
Yes, you,
First,
you call the
first
help.
one.
Okay. Okay.
So I need to tell what the help consultant and neonatologist.
Yes. Okay. So now if I told you now that room 3, okay, now in severe bleeding, will you go to room 2 or room 3 first?
Three.
Yes. So you can here ask the help of the SHO to start resuscitation of this patient, taking observation and examination, and they start on the resuscitation along with the help of the resuscitation team while informing your consultant about this case. Why not? Yes, we can. Okay, this is mostly now a medical case, and you have SHO who can do the observation for this case and can inform your consultant while you are running to the major obstetric hemorrhage case. Right? So now become, look, this is what's called the evolving scenario. Evolving scenario means that the case was written like it's an innocent case, just a case with second-degree tear awaiting the suture. But the examiner, when you ask the examiner about the vitals and examination, it was good from you. Okay, I like that. So the examiner have revealed the hidden agenda, and he told you that the patient is bleeding and it's severe bleeding, and also he mentioned that she's now vitally unstable. So here, yes, here you have to alert the team, declare the emergency, activate the major obstetric hemorrhage protocol, right? Team to help you, okay? That will be, of course, a senior midwife, and your consultant will be aware, and hematologist, right? And the anesthetist, okay? And one important thing, okay? What it is, yes, you start on the resuscitation, ABC, of course, 2 wide bore cannula, and you start on the fluids. Very importantly, that you have to send for the blood investigation and check the patient for the blood transfusion, whether the patient would accept that or not, right? And if the patient did not accept the blood transfusion, you have to check for the availability of advanced directive, okay? And also, you have to, why your consultant and hematologist will be aware, because they will help in trying to find a way to stop the bleeding if the patient refused the blood product. Another point here, okay, this case will be managed in the room now or will move to theater. And to have as witness, okay,
Theater to make a
we will escalate the situation fast.
Early recourse.
Yes, so we will go early or we will move early to the theater. Okay,
yes.
so you are working as a team. You are trying to resuscitate somebody, and you examine, you assess what is the source of the bleeding. Is it the tear or it is the atonic postpartum hemorrhage? Okay, so if it is atonic, then you will start it on the uterotonic, right? If it is the tear, then you will put it back and you will inform the theater for better examination or for proper examination under anesthesia, right? So those are the things that you need to manage right now, okay? If the examiner asked you or he wanted to proceed further in the steps of the management of the postpartum hemorrhage for this case, he will do. Otherwise, okay, you have mentioned the point of safety that he wants to listen to it, okay? Which is first of all, you asked about the vitals, assessment of the patient. Well done for that. Secondly, you started the resuscitation, and when you started the resuscitation, start stepwise approach and ABC, please. Right? You alerted the team, right? And specifically you mentioned the hematologist and your consultant and the anesthetist, okay? And you have mentioned about sending the blood investigation required and 2 wide bore cannula and start on the warm fluids, and you asked about the acceptance of blood and blood product, and you inquire about the presence of advanced directive, right? And you have examined the hair and early resort to the OT, okay, to trying to find what is the source of the bleeding and arrest the bleeding earlier and offer intervention sooner than later, right? If the tonic postpartum hemorrhage, you will work on the medical part, then surgical part. If it is only comes from the side of the second tear, okay, then pack until you move and stop the bleeding under anesthesia. While you are doing that, you have to inform the patient about the situation and take her consent for the even verbal consent, okay, for moving to theater, while also alerting the team. One of the team, like the midwife, can alert the OT theater team. Okay, so it's a hot situation, so your answer should be a hot, okay, answer as well, and fast. So now you will find that you have almost spent 1 minute here, 1 minute here in the case number 2, 2 minutes in the case number 3, and it appeared like it's your top priority now. Now, in your planning for the next cases, you have to, you know, only spend 1 minute or even less in every case. So in the case number 4, this is a confirmed delay or suspected delay in labor.
And only 30 minutes.
Yes, so it's suspected, right? She's multipara, right? Isn't it? Yes, she's multipara, and she's grand multipara actually. Okay? She's gravid 7 para 6. So for such case, you have to say that this is suspected delay of labor. This is what you will say. What is the background? The background that the patient is gravid 7, right? Okay, so you know that there is increased risk of some complication, and we should expect that this patient progress fast. So what prevent her? I need to assess her, right? Shall I do the assessment now myself among all of these emergencies, or what?
Midwife is assist.
Yes, the midwife can assess her
Midwife.
right, for the progress, and she can inform you, or you can repeat the assessment after 15 to 30 minutes. One point you asked about, and it was good, and I really, give you a star for this, Dr. Suzanne, which you asked about the CTG, right, of the baby, or you asked about the fetal heart rate, which was good. So fetal heart rate is normal, then there is no urgency here in this situation. This situation now, okay, is just a semi-urgent because it's only suspected delay. But a point to remember or to mention to the examiner that we expect in a case of gravida 7, okay, and para 6, that you progress faster than this. So what is the possible causes of the delay? In the assessment, I need to mention the abdominal assessment, okay, and the contraction, baby size, and the engagement and the descent, okay, and also the same for vaginal examination, exclude any malpresentation, cephalopelvic disproportion, right? And then manage the case or give more 30 minutes, then reassess. If the case progress, then we advise also active management of the 3rd stage because of the gravid 7, right? Because of the multiparity before. So this is what you will mention, and this will be more than enough. Okay? Okay. So now we will ask next. Thank you very much, Dr. Suzanne. This was good. And hopefully that your participation next time will be even perfect. By practicing only, my dear, you will be perfect, inshallah. But so far, I can see that this is a good start or a good level, inshallah. You will do best. Okay, so we have said at the beginning that Dr. Tanya should be next. If Dr. Tanya is available, please come on.
Yes, madam.
Hello, Dr. Tanya, how are you? Okay, so Dr. Tanya, please take the last 4 cases for me. I will start your timer now.
Okay. So for room number 4 or 5? Oh, okay.
5.
For room number 5, the patient is 4th gravida, now 31 weeks, suspected preterm labor. So for this patient, any information available, I would like to know patient vitals and also the para-abdominal and para-vaginal findings and CTG findings.
Okay, so what is available that this patient comes with contraction, with suspected preterm, and the fetal heart rate is okay. What's your recommendation for management?
Okay, so for this patient, the contraction, I would like to follow up of the patient and also the monitoring of the baby by CTG. Also urine will be sent to see any depistic test for see any infection, and also arrange the ultrasound scan to see the estimated fetal weight. And if this is actually suspected preterm, so the patient will be informed about the pros and cons of preterm delivery and regarding the mode of delivery. So I would like to
In your ultrasound assessment, anything else will you look for?
yes, the placental localization
Okay.
and and the amniotic fluid index.
Okay.
And here they inform the consultants and neonatologists to speak with the patient regarding the prognosis of this delivery. And here we will also do the ultrasound transvaginal scan to see the cervical length to diagnose whether to confirm the preterm labor.
Okay.
And also we can arrange the fetal fibronectin test. So this is a semi-urgent case. I will send my senior midwife to go and manage this case. Room number 6, the patient is a known case of vulnerable type
So the
3.
midwife will do the ultrasound?
No, arrange ultrasound. So the patient will this patient will be referred to the fetal medicine unit for cervical length measurement.
Okay.
Room number 6, this is a multipara patient in later stage, a known case of volumeral factor type 3. So this is for this patient, I would like to know and what the estimated fetal weight and per abdominal per vaginal findings.
The
Any
estimated fetal
information?
is 3 kg and she is still in the latent phase.
Okay, the patient will be followed. The patient will be followed by routine care, and here I would like to inform the hematologist for this patient, and IV excess blood will be sent for group match and safe, and for this patient factor 8 level will be done, and also exclude any reservation for blood transfusion or not, and also inform the neonatologist, and for this patient avoid the traumatic vaginal delivery, and and this is the semi-urgent case, so midwife will go there. And here room number 7, the patient was 36 weeks breast for external cephalic version. So this is the non-urgent case for this patient. After the constant will be taken. For this patient, I would like to review the scan report to see the placental location.
Okay.
And here before this is a non-urgent or routine case. Before external cephalic version, consent will be taken and also CTG will be done. And after doing the external cephalic version, we again arrange the CTG, and here consent will be taken for need for emergency cesarean section if any concern of the fetal heart rate or placenta. So this then accident and emergency. There's a patient with abdominal pain and urinary pregnancy test positive. So this is a suspected ectopic pregnancy. So for this patient, I will send my ST2 to go there and also inform. Yes.
Yes, time is over. Thank you very much. Okay. So, is that a case of ectopic or one of the differential diagnoses is ectopic?
This is the case of ectopic or other differential diagnosis can be keep in mind, like
So,
torsion of the ovaries or urinary tract infection.
okay, so you don't know really what is the cause of the abdominal pain, so you are going to send your ST2 as you said, okay, to assist the patient, okay, perform an examination and send laboratory
And
testing.
update me. Yes, update me.
Yes, okay, and if it is now, it is in the morning, okay, so we can book her for a scan, and unless it's urgent, unless the patient is unstable. Okay, so my dear, time management again, please take care of the time management. Sometimes we don't notice how slow when we speak, or we don't notice also how long did we spend in one task. Okay, for the task that have number 5, it was a suspected preterm. In any preterm, my dear, okay, you need to first of all, okay, this is a preterm, right? If there is any background currently, any background maternal or fetal risk or not, okay? So this is this bar. You can mention that and move. If the examiner want to tell you information, he will tell you. Otherwise, the examiner will stay there looking at you. Okay? Then you will go to the assessment. Assessment of any case of the preterm, okay? That's mean you will need to perform abdominal and perspiculum examination, right? For the arrangement of the vaginal examination, transvaginal examination for this gestational age, my dear, okay, this will be a bedside test. You don't need to refer to fetal maternal unit, okay? You are now in the labor room. So it can be a bedside test, right? And this can be done by your ST2 or ST3 if it's there. So just to assess the cervical length of this case, right? Why? Because if it is suspected preterm, clinically, okay, you can rely on the clinical, and also what is the test that you can do if you want to assess. You have to assess the cervical length. Cervical length of less than 15 or less, that means that the patient is at now in labor, in suspected preterm labor, or otherwise this can be, if it is longer than 15, then that's mean she is not in preterm labor and consider other differential diagnosis. What can I give to this patient at the moment as part of my my recommendation? I can, yes, inform my consultant, inform the neonatologist, plus you have arranged the scan for her. And in suspected preterm labor, I can assess the contraction and give tocolysis if there is no rupture of membrane, of course. And I can also give steroid, the first dose of steroid, right? So this is what I can offer so far, right? After you inform the neonatologist, the part of the informing the neonatologist, check availability of COT if the lady in preterm labor, okay? We don't count the patient about the pros and cons of preterm delivery. We count the patient about the outcome of preterm delivery, okay? So it's nobody actually like the preterm delivery. There's no bruise of it unless it's for some reason to save the mother life or baby life. Otherwise, it's just, to make the patient and the family aware of the possibility of the preterm delivery and what is the complication in it. In room number 6, this is
Ma'am,
seems
then who will do this cervical length measurement? ST2 or a midwife?
if your ST2 is competent to do the performance scan, or otherwise can wait, okay, till you finish the emergency and you perform the bedside scan, okay? So here looks like a big case for you. This is the von Willebrand disease case. What is the risk of a labor of a patient with von Willebrand disease? Apparently, the risk is the bleeding, right? So the von Willebrand disease is the good type, or it is the most severe type?
Severe type.
Yes, most severe type. So this patient, you have to be careful, okay, with her. You have said something about the factor level. Do you want to revise any notes for this patient after you inform your consultant about her presence?
Factor level I have to check during
Have to
delivery.
check. You have to check the
Any
patient.
treatment,
Yes.
any treatment desmopressin or any factor transfusion, 100 factor previously.
Okay. Yeah. So we need to know about this patient, background. That's very important for a safe management of this case. This case also, please avoid, because Dr. Tanya Majid, you said this patient for routine care. Okay, please, please, please take care. She's not for a routine care. This patient is high risk in labor, right? So just watch the terms that you use, right? Okay, I'm afraid I can explain that to the examiner. I'm afraid of the risk of bleeding in this case, okay? And I'm afraid also for which? You're afraid for the baby or not?
Baby also, because they may be having intracranial hemorrhage.
Okay, so my dear friend, okay, this is von Willebrand disease. I can't send the midwife for her. At least I need to send ST2, or if I have only one ST1, but obstetric SHO, I can send. Okay, so ST2 can take the history and review notes for me. Okay, you need to know about exactly the patient, the factor level, okay, and any treatment receive. Okay, how was the testing of the baby, right? Because if the baby is identified during antenatal as having the disease, this will be very even high risk. Okay, so we need to know the status of the baby is known or not. The monitoring should be throughout labor by CTG. If the factor level, okay, is less than 0.5, then we have to offer the desmopressin, right? And we aim for 1. Avoid IM injections. This should be like instruction you give to all the staff. Okay, instrumental assisted vaginal delivery, like as you said, interventions. Okay, and testing. Inform the neonatologist and test the baby once the baby is born, sorry, and inform, of course, your consultant about the presence of the patient, pediatrician, and hematologist, and give a note that vitamin K should be given to the baby orally. Okay, for the management of this labor, continuous management of this labor, we can also start on the tranexamic acid afterwards. But now, at least for now, I give my instruction, okay, to my team, okay, what to do. And I'm going to send the SHO, not the midwife, for this patient, right?
Okay.
Okay. So, von Willebrand disease came before as a case, so you guys please revise the von Willebrand disease. It can come again as part of the labor ward, or can come as part of counseling, or even a structured discussion. Now we have the breach for ECV. This is a routine case, as you said. Okay, so we are going to send here the midwife to explain to her the situation and how busy is the labor room, and to check for the fetal heart rate. Okay, and if afterwards she will need a range ultrasound. Okay, she can be attended by the consultant after finishing the emergency, right? And here the case of the A&E, as we said, you are going to send again one of the SHOs, that just to assess the patient, okay, offer assessment and examination of the patient, and to know more about this abdominal pain and the type of this pain, and the need for extra investigation like TVS or beta HCG, okay, if you are suspecting the ectopic. If the patient is stable or not stable, that's a very important question to ask, so you can determine the urgency of the case, right? So this is about the labor ward. How about the prioritization, my friends? What do you think about the prioritization of these cases?
Room number 3.
Okay, so the major obstetric hemorrhage comes first.
Then room number 2.
Okay. And will be managed by whom?
Room number A by consultant, and also the consultant anesthetist we can involve, and hematologist. Room number 2, I will say
room number 3, you have to attend yourself. Okay. Yes, you are going to inform everyone in the team, consultant, your consultant, hematologist, and even consultant anesthetist, because you have a witness. Okay, but you will say that you will go first to this room. Okay, you have to go first yourself. Active bleeding, you have to go. Okay, so room number 2. Okay, this can be attended by the anesthetist, right? The registrar, and with one of the SHOs, right? To start the 6 bundle, right? And yes,
sepsis 6 bundle.
yes, and then you will inform the consultant, and you can attend the case next. Okay, so who's else?
Then in case of accident and emergency, if the patient is unstable, then
Which
that will be
Sorry, which case?
accident and emergency. If
According,
patient is
yes,
unstable.
if according to her. Okay, so let's say patient is stable. So
Okay.
which case you will go for? I have a case in labor.
Then room number 4.
Okay. Would you like to go room number 1 as active labor? Or you go the case in the latent phase? Which one you go for? Or the suspected preterm? Which one?
Room number 6.
Number 1.
No, go to the case, okay, that it will make different in her management. Go to the suspected preterm and then the PBAC, okay? And then you go to the von Willebrand disease, because the von Willebrand disease is still early, still latent.
Latent, yes.
Yes? Okay. Right?
So room number 5, then room number 1.
Okay. Yes, then 6, then 8, then 7. That's it.
Yeah.
Okay. Okay. Thank you very much, my friends. Okay, and hopefully that it's not too late in your time now. I have tried to stick to the 3 p.m. and hopefully that you liked this time. Okay. And I see you in the next session. Thank you very much, my friends.